everyone. Today I am going to present our paper titled on Acceptance Evaluation of a COVID-19 Home Health Service Delivery Relational Agent. So here is the problem statement actually for this work. We started this work during the COVID-19 peak because like COVID-19 restricts patients to see the doctors in person. And in that case, some doctors are using the telehealth services. But the thing is, telehealth is constrained due to the availability of healthcare professionals during night or any kind of emergency situation. And also, though the systems and the existing technologies are helping patients about their infection or their treatment, there was a lack of post-infection care for the patients who just recovered from the COVID-19 infection. So we can call it the post-traumatic stress disorder among the patients who just recovered from the infection. Here are the motivations that worked for our research, because like we found that mobile health uncovers a lot of door to the healthcare services through telehealth or distance technologies. So mobile health or AIM health uncover the door to relational agents for healthcare services as an alternative to healthcare workers or healthcare professionals. So also we went through the earlier research and found that virtual agents and relational agent-based systems could be an alternative to healthcare professionals for the non-life-threatening care scenarios. Also, relational agents can play a role of healthcare professionals during COVID-19 because earlier exploration on virtual agent-based solutions had the potential to provide with a variety of COVID-19 related home care services. After going through the literature and exploring the existing systems, we found three main research gaps. And the research gaps are as follows: like existing virtual agents are usually targeted towards the healthy individuals. We found no virtual agents that were targeting the infected patients, and most of the virtual agents were actually giving suggestions and guidance for testing and symptoms. There was no virtual agents that could help patients during their infection time or after the recovery period. Also, it was actually remained unknown whether general people were willing to accept a virtual agent-based intervention during COVID-19 or whether they are willing to use or accept these for their home care during a COVID-19 like pandemic. Another factor was that it was unknown whether or which socio-demographic factors influenced people's willingness to use a relational agent-based system and accept such intervention during COVID-19 pandemic. To address these research gaps, we initiated our work. So our contribution is actually threefold. Initially, we used user-centered design methodology to identify the gaps and identify the design requirements such as user personas, interaction scenarios, and so on. Then we designed a relational agent that can serve people during COVID-19 at home. And finally, we evaluated that relational agent in terms of its acceptance by the target stakeholders like the infected patients. And we wanted to see if our proposed array can serve as an alternative to healthcare professionals during COVID-19. So this is our overall design process. We started with the user persona creation. So we go through the design, that we go through the CDC's guideline about COVID-19 prevention and diagnosis. With that study, we found 3 user personas. Then we developed 4 interaction scenarios with the help of target stakeholders, patients, and healthcare professionals, where the 3 user personas are utilized. Later, we developed interaction dialogues. We developed 4 sets of interaction dialogues for scenarios so that each scenario has unique conversations between the relation agent and the user. Finally, we designed our prototype, that is a web-based prototype, and it can be accessed through a smartphone or computer or laptops. We found 3 user personas, and they are the person who is suspecting infection, the person or persona who is currently at home for quarantine, and the person or user persona that is recovered from the infection and he or she needs post-recovery care. Here are the 4 interaction scenarios. The first one is testing guidance, where the user is not sure about the testing. The relation agent can guide the user about the testing centers or whether the user needs any testing or not. Then another scenario is about the supporting the user during self-isolation at home. So it means the relation agent will monitor the user's all vital physiological signals and other factors so that it can guide the user to be healthy during the self-isolation. The third interaction scenario is about handling emergency situations of patients. Like if a user needs a emergency attention, then the RA can act as the emergency respondent. Like if a user needs to call an ambulance, if the RA can detect this, then RA can call the ambulance on behalf of the user. And the final one is post-infection care among the recovered patients. Due to the infection, almost all the patients in our study mentioned about the post-traumatic stress due to their nearly life and death situation and the hospital stay. For the unique 4 interaction scenarios, we developed 4 sets of interaction dialogues. So for each scenario, there will be a set of dialogues or conversations between the relation agent and the user. Then the conversation are actually validated and refined by another group of healthcare professionals. This is our prototype. So here we are presenting some snippets for that proposed prototype and proposed array. So if we see from the left to right, at first we have the interface avatar of the proposed array or relational agent. So in the final deployment, this avatar will be presented in front of the user so that the user can feel a real life partner to communicate. The second figure is for the first scenario, this one is for second scenario, this one is for third scenario, and this one is fourth scenario. Actually, the user was interacting with the array using voice and touch. For better understanding, we made our prototype accessible as a chat bot so that the user also can see the communication like chat messages. So for the proposed array, the prototype, we evaluated in a 2-way. So our primary or preliminary evaluation consisted of two different phases. The first phase was acceptance study and the second phase was checking statistical significance using Wilcoxon rank sum test. So for the acceptance study, we assessed actually if people would find the proposed RA intervention beneficial or people would be willing to use and accept it. For the statistical significance, we tested three hypotheses about perceived usefulness, acceptance, and willingness to use the system. We specifically checked if the perceived usefulness is dependent on history or status of infection, participants' demographics, and or previous experience with mHealth apps. In terms of acceptance, we checked if the acceptance is dependent on infection history, participant demographics, and so on. And for the willingness to use the app, we checked if it is dependent on status of infection, participants' demographics, and so on. Here are the summary of the participants who participated in our study. We had 105 participants aged between 18 and 64 years, and the number of male participants was 74, number of female was 31. So here you can see the overall distribution according to the attributes like infection status, gender, mobile health app experience, and COVID-19 mobile health app experience. For the evaluating acceptance, we asked three specific questions to the participants, and the participants were responded through 5-point Likert scales. For the perceived usefulness, we asked participants to rate the usefulness of the COVID-19 related health services provided by the proposed RA. For the willingness to accept the RA, we asked participants to indicate their willingness or unwillingness to accept it as an alternative to caregivers or healthcare professionals during COVID-19. And finally, for evaluating the willingness to use the proposed RA, we again asked the same participants to indicate whether they were unwilling or willing to use the proposed relational agent during COVID-19. So from the acceptance evaluation study, these are our findings. In terms of perceived usefulness, overall 80.77% participants thought that the RA would be either very useful or useful to patients. And you can see 17.31% are neutral about the modest usefulness. Whenever it is about willingness to accept, the majority, the 60% of participants agreed that the RA could be an alternative to caregivers or healthcare professionals. And finally, in terms of willingness to use the relational agent, overall 78.10% participants expressed their willingness to use the proposed RA. The good thing is nobody voted for very unwilling, and only 0.95% are unwilling to use the relational agent. And this is the findings from Wilcoxon rank sum test. So here astar means the number is statistically significant. So if we can see here, for perceived usefulness, infected versus non-infected participants had a statistically significant result. Also, in terms of age, less than equal 30 years versus greater than 30 years had a significance, and also mHealth experience had a significance. For willingness to accept the system, we found only one statistically significant result about the age. And for the willingness to use the proposed system, we again found another significant outcome for age. In other words, the participant with age less than 30 years versus participants with age greater than 30 years. Our work had some limitations actually, because our findings can only be viewed as preliminary indicatory for further research, and we did not gather any qualitative data from the participants to understand the reasoning behind their responses to the questions. We also did not make the equal number of participants in the study. So for more rigorous and appropriate statistical analysis, we will need to conduct this study again with the equal number of participants in terms of gender, in terms of infection status, and also in terms of age. As of now, we have not conducted any kind of field trial of our proposed array. We collected the data through a prototypical app, through the website and smartphones. So to understand the actual feasibility, we have to go for a field trial of our proposed array. For the next step, we believe that further research is needed to understand what factors can improve the perceptions of usefulness of the proposed tool in terms of the user's age and infection or non-infection status. Actually, we aim to understand the acceptability and willingness to use the proposed array before conducting a long-term trial. So that's all. Thank you.